This episode of Healthy India, we are going to talk about one of the most major advances in medicine that has taken place over the last 3 decades or so, and that is kidney transplantation. A few months ago, we discussed all about kidney disease, its causes, and prevention. And those discussions are available on the Sunset TV YouTube channel. We know that when kidney disease becomes chronic, it is sometimes irreversible. Means that it's going to remain chronic or slowly progressively worsen. The kidney disease is called end-stage renal disease, ESRD. And when we reach this point in our journey of kidney disease, then often we have to resort to measures like dialysis or transplantation. To discuss all these aspects of this very important area of kidney transplantation, I have a bunch of experts with me today. Dr. Anup Kumar, who is the professor and head of urology and renal transplant at the Safdarjung Hospital in Delhi. We have Dr. Himanshu Verma, who is the professor and head of nephrology and renal transplant at the Safdarjung Hospital again. And we have Dr. Anant Kumar, who is the chairman of urology and kidney transplant at the Max Healthcare System in Saket. People who have tremendous experience in this area. And we hope to learn all about kidney transplant from our guest today. So let's start with something very basic, Dr. Anup. What exactly is kidney transplant? I mean, you take out the kidney of the diseased person and put in a new kidney? What exactly happens?
What is kidney transplant? So what we are doing is we're taking out a kidney of a healthy donor. As we know, we have two kidneys and we do proper screening of that person so that we can take out one kidney from that person. We take out that kidney known as donor nephrectomy, and then we put that kidney into the recipient. And this is known as allograft, because there are three kinds of graft. One is autograft, which means we take out the kidney of same person and transplant into the iliac vessel, that is autograft. Allograft is when take out the kidney of the same species but from some other individual, that is allograft. And xenograft is when take out the kidney from the animal and put it into humans. So this is allograft. So we take out the kidney and we anastomose the artery to one of the major vessels in our recipient, which can be external iliac artery or internal iliac artery, vein again to external iliac vein, and ureter, which is anastomosed to the bladder. So these are three anastomoses we do. And
so artery, vein, and ureter all are then stitched with the recipient's original system.
And we leave normally both the kidneys of recipient in situ, except few cases in which we have to take out one is pre-transplant nephrectomy, which is required in
by and large, you leave the kidneys, the diseased kidneys in situ. They're not taken out. So we just attach a fresh kidney with the correct attachments and drainage as you
we put that kidney in the iliac fossa, mostly the right iliac fossa and sometimes the left iliac fossa.
So which means lower down than the usual kidney. So the transplanted kidney from a donor, taken out from a donor, is placed into the recipient, leaving the recipient's kidneys intact, lower down in the abdomen towards the iliac fossa, and that is what takes up the function of the normal kidney for that recipient, right? Fantastic. So, there's always this debate, Dr. Himanshu, about when we reach end-stage renal disease, whether we should go for dialysis, like maintenance dialysis. We're not talking acute dialysis here. So maintenance dialysis, or we should actually go for transplantation. And there are pros and cons, and there are some countries in the world that prefer long-term dialysis, and there are others who straight away prefer for transplantation. So what are the pros and cons of these?
Once the patient reaches the ESRD stage, means now he needs renal replacement therapy. Renal replacement therapy means he needs either in the form of dialysis or a kidney transplant. For dialysis also, there are two options. He can go for hemodialysis or he can go for peritoneal dialysis. Now, as this is a lifelong thing, so if a patient is young patient and he is he's end stage renal disease, and he opts for the dialysis, so he has to do this dialysis procedure for lifelong, which has many restrictions. He has to go for the work also, and cost effectiveness, if you see, then the dialysis in the long run costs much higher as compared to the renal transplant. So if the patient opts for renal transplant, then he has to take immunosuppressive drugs throughout the life, but he leads a life just like a normal person. He can do his work. So if you compare in the long run, then transplant is much cost effective as compared to the dialysis. But as we are seeing, I want to share some figures. The global burden of CKD is approximately 8.5 crores, and approximately 26 lakhs patients are on dialysis or transplant. So there is shortage of organs.
Yes.
There is a gap between the recipient and the organs. So to meet that gap, government and other agencies are working to reduce this gap of organ shortage through various awareness programs and through various policies, government policies, uh, promoting the cadaveric brain-dead donor donations, live donations. But only 10% of the patients who reach ESRD are able to get a organ renal transplant. So to reduce this burden of CKD, we need to promote more and more renal transplant programs so that we can have more and more patients who can get these kidney transplants and will lead just like a normal healthy life. But other patients, for their survival, they have to opt for the dialysis.
So I think that's very important. The message is very important that donating a kidney, if of course advised by the doctors and the matching and the processes are complete, is actually fairly harmless for the donor. Especially, I mean, obviously the donor is a healthy person. You do not face any consequences. So this fear of donating has to go out. Donation of kidney is a very noble thing and can save a life. And if it matches well with the recipient, it can be done. So we really need to get away from this hesitation about family not being willing to donate their kidney for a sick patient, a sick family member. So this is a very important message, I think, that we all need to carry back. Dr. Anant, now you deal a lot with this. You know, when Dr. Anant and I were starting a transplant was just starting in the country. It was a big deal because it was going to get kidney transplant done, and the results were also not that gratifying at that point. But we've seen over the years how this has changed and how beautifully now, how dramatically now you can improve the quality of life of a person by providing transplant. Dialysis has also improved a lot. So quality of life in dialysis, even though you have to go to the hospital 3 times a week, usually, unless you're doing home dialysis, by and large, even there, the quality of life has improved, but quite clearly, transplant makes a world of difference. So patients, Dr. Anand, that you are transplanting now, and who are the ones you're saying no? I'm talking obviously of EA patients.
And nowadays we are transplanting almost all patients except those who have a short life expectancy. Suppose they have a bad cardiac disease, they have a bad cardiacs, they have strokes, and their life expectancy is not much. They are not going to live for 4 years. Even if you do the transplant, so there is no point in taking the kidney from one of the relative or from the cadaver and waste that kidney, because anyway patient will not live for more 4-5 years. So we usually give the patient, even if it is not the contraindication, even if patient is 70 years, if he doesn't have so many comorbidities and with the transplant he will live a good life, then we give the kidney to most of them. And we transplant all kind, even if small kids 3-4 years can get transplants. People with any other problem can have except the life expectancy is not much.
So basically, if someone is unlikely to live very long
Yeah.
because of other disease, then you probably would avoid transplant. What is the typical life, usual life of a kidney you transplant into a person?
Yeah, and it has improved dramatically. Like, just give you a figure, if we do kidney transplant now, first year, almost 97% patient do very well. 2-3% patient lose kidney either because of the rejection or infection. At 2 years, that drops to 95%. And
95% are doing well at 2 years.
but 5 year, it is now coming around 80%. I'm talking about the good center in the country. And 10 years is 60%. So you can see that 60% of the patients are doing well at 10 years. After that, attrition rate is little higher. It drops percent in 15 years, and around. But those people who cross 15 years, then they live without much problem, because by the time body has tolerated the kidney, and we have patients with 33 years, 34 years, 28 years, 27 years living very well. But once they cross 15 years, then they live, and then attrition rate is very low.
So, one question to you before we take a short break, Dr. Anoop. We were talking suddenly of living and cadavers also. So, what is the story of living versus cadaveric transplant?
Yeah, so that's a very important question. I want to explain in very simple terms so that the audience can understand that. As Dr. Himanshu said, there's a huge gap between demand and supply. So the government has introduced this new act, Human Organ Transplant Act, which legalizes the donation of organs from a brain dead patient. And we call that is a diseased organ donor. Initially, it used to be called a cadaveric donor, but that's doesn't look nice to speak and hear. That's why the name has been changed to diseased organ donor. So what is the diseased organ donor? If a patient becomes brain and they are set norms how to declare brain death, 2 times the examination is done 6 hours apart to label a patient as brainstem dead, which is practically he's dead, but his organs are still having some perfusion. So we have to maintain that donor till we take the consent from the attendants and retrieve the organs. It is a disease organ donation. And that patient, one patient can save 8 lives. We can take out 2 kidneys, 1 heart, 2 lungs, liver, and even intestine and pancreas, and 2 corneas. So this is what this organ donation is all about. And that's how, if we convert this pool of potential disease organ donors into reality, we can actually match this gap.
So I think that's very valuable information. We learned about living donors and how it is safe for people to donate kidneys, and we learned about the underuse of disease organ or cadaveric donors, especially in our country, a program that needs a lot of push. And I know all of them making a lot of time, but that really needs much greater awareness and much greater push actually from all directions, so that we can overcome the shortage of kidneys for our patients. We take a short break here, and we'll be back with more soon after.
Parliament in session. Day's legislative business. Debates and discussions. Catch the high points. All the updates. Highlights. Monday to Friday at 10 p.m.
Welcome back after the break. And I go to Dr. Himanshu. You being a nephrologist, how do you choose a donor? We're talking of living donors, obviously. How do you decide who can be a donor?
There are 2 types of donations, as Dr. Anoop has already briefed about the brain dead donors. For the live donors, the thing is, we can take the kidneys according to the HOTA Act, Human Organ Transplant Act. Legally, parents siblings and children are allowed, and wife. These there should be first degree blood relatives who can legally donate a kidney. And the donor should be healthy. Healthy means he should be free from any type of chronic disease like a diabetes or any type of malignancy, any chronic infection like hepatitis B or C infection, HIV. These patients are excluded from donation, and a battery of tests are done, starting from the routine investigations of hemogram, KFT, LFTs, up to the CT renal angiography. All the investigations are done, and if the donor is perfectly fit to donate a kidney, means that after donation of the kidney he will not have any risk of a kidney disease. So those donors are taken, and all the legal formalities, legal documents are prepared. It is a time taking process, and after that the donor can donate a kidney to the recipient.
So, Dr. Anoop, are there any risks to the donor?
So that's a very good question because often the patient families also ask us.
I mean, it's the right to ask.
Right to ask. So it has been seen in the many publications that we follow up a patient who donated the kidney over a period of time, 20 years, 30 years. There is no added risk over general population, number one. Number two, once a patient donates kidney, the other kidney undergoes compensatory hypertrophy, and the GFR of that kidney increases. And it has been seen many patients that GFR increased to 17, 80 ml GFR per minute of the opposite kidney, and takes up the function of the kidney which we have removed.
So one kidney is removed, kidney picks up and takes up the function.
And there is some risk of mild proteinuria and hypertension in the follow-up, which you have to rigorously follow up the patient for lifelong. But as I said, no risk, added risk as compared to general population. Very safe to donate kidney, and patient leads a very healthy life.
So, Dr. Anand, there's a concept of early transplant. We were talking of advanced kidney disease, ESRD, etc. But now there's also something called preemptive transplant, and I know that you've been practicing that also. What is that?
Yeah, actually, in simple term, I tell everybody that you should catch a train when train is standing at the station. You can go there, sit. Don't try to catch the train when train is running. So preemptive transplant is like that. When you are reaching to the stage of going to the dialysis, you are still fit. You still don't have severe edema and severe hypertension and fluid overload and other problem. That is the time if you undergo kidney transplantation, complication rates are less. You can avoid dialysis and your recovery will be faster. And you can avoid putting the neckline or AV fistula and other things. So that is the preemptive transplant. So it is better. And we do it when the patient has reached to the stage where is about to go on dialysis. So by doing that transplant at that time, results are better, complication rates are less, morbidity is less, and patient recovery is very good.
So that is increasingly becoming popular, preemptive transplants. But you know, Dr. Himanshu, these patients require a lot of care through their life. As we said, they require immunosuppressives and they require sometimes steroids, where the endocrinologist comes in and the sugars go all over the place. What is the kind of care? How taxing is that care through the life of a patient?
Actually, renal transplant patient, they have to take the immunosuppressive drugs which keep the immunity of the body down, because an organ from another body has been transplanted into their body, and the body has a tendency to reject it. So to avoid, we have to lower down the immunity with immunosuppressive drugs. There's various category of drugs are there. Commonly used are the steroids, CNIs, and anti-proliferative agents like azathioprine or mycophenolate. So they actually, initially, if we talk for the first 6 months, they are at a higher risk of infection as compared to the general population. They can catch, so they have to, we just advise them to remain at home and try to keep the surroundings clean, maintain strict hygiene for at least 6 months post transplant. After that, they can carry out the general activity just like a normal individual, and the risk of infection is minimal, but it is there. So they need to prevent that infection, because there are only two important complications that appear post transplant, and the patient comes to a nephrologist either with an infection or with a rejection. So the nephrologist's role is to balance, because if you lower down the immunosuppression, there are chances that the patient can have a rejection, and if you increase the immunosuppression, then there are chances that patient can catch some type of viral infections which a normal individual does not carry, like a cytomegalovirus infection or Epstein-Barr virus infection. So we have to maintain that balance, and the patient is advised that you maintain the strict hygiene, because you have to take this immunosuppression for a lifetime.
So those precautions have to be maintained, but with precautions,
With precautions,
we get pretty good results nowadays, as we discussed.
Good results.
So Dr. Anoop, just quickly, we've already talked a little bit about long-term outcomes. What about their quality of life? Are people actually able to maintain good quality of life? Of course, we see them all the time. Half the people, these doctors, these experts, transplant are actually people with diabetes who go through us, unfortunately. And if you actually manage their diabetes well, they should never reach that stage. But nevertheless, some of them do. What are the long-term impact on quality of life?
So as we discussed earlier, that renal transplant is a better option when we talk about the longevity and the quality of life as compared to dialysis. So there are studies, we have published literature where patients who have undergone transplant, they have got married, they've produced children, and they are leading a very healthy life. Up to 25, 30 years, we have data. And as I said, for the first year is a very important time when you can have all kinds of complications like infections or rejection. Once the first year passes, then the chances of complication decreases. And that's why we advise the patient that if the patient is not married and has not produced any children for at least 2 years after transplant, before he can think of either getting married or to produce the children. But once that period is over, we have patients who are coming to our hospital, they already are married and they have already produced children. But yes, they are at higher risk as compared to normal population, but quality of life is pretty good if they follow rigorously what we are telling them under a strict follow-up of nephrologist and urologist. And of course, nowadays it's a teamwork. Endocrinologist is also required, because sometimes they take steroids, as you said, they become diabetic. And cardiologist also might be required, and a dietitian, because these are the team, and the psychotherapist. The all team is required for a good follow-up. But if they rigorously follow this, all these follow-up, they will lead a very good life.
We are nearing the end of the program, and I have a couple of questions for you, Dr. Anand, before we sign out today. One is about this rejection. How common is it, and how is it manageable most of the time? Acute and chronic rejection.
Yeah, the rejection happens even if well-matched kidney is around 10% of the time. And out of 10%, out of 10 people who get rejection with proper treatment and prompt treatment, around 7 will recover. 2 or 3 may not recover. And rejection is also nowadays that there is a development in that, like 20 years back, antibody-mediated rejection was not identified. Now it is being identified, which is more dangerous. But with the proper therapy, some of them recover, some of them do not recover. And some of time kidney get injured and recovery is not full recovery. So they may have some consequence later on. This is acute rejection, which like vascular rejection, cellular rejection, and antibody-mediated rejection. Severity of rejection will also decide the fate of the kidney. But we have a good rejection treatment. If it is identified well in time, biopsy is done and treated, then around 70-80% will recover.
70-80% of those who
will recover.
Do have problems of rejection will recover. From that. Fantastic.
But those who have very severe rejection or have antibody-mediated rejection may not recover. Earlier the rejection, it is bad, and most of the time earlier rejection is antibody-mediated rejection. The other type of rejection, which is known as chronic rejection, which are also termed in different ways like transplant, glomerulopathy and other things, that happens few years later, where there is a severe, slow deterioration of the kidney function, and it is multifactorial. It could be because of the ongoing T-cell rejection. It could be because of the associated metabolic syndrome, which could be associated some chronic infection or atherosclerosis and all that, which all put together is contributed and labeled as transplant glomerulopathy. That is not reversible, and slowly kidney is destroyed and deteriorates. But nowadays we control all factors like metabolic factor, infection, viral infection, immunosuppression, and immunosuppression titration is also very effective. So if you are taking very good care in all aspects of it, then even chronic rejection rate goes down and patient kidney lives longer.
Thanks for sharing all that information. Very, very important advances in this area. As I was joking with Dr. Anand Kumar, it has changed completely from when we started our careers to now. And we see so many of our patients, most of our patients who end up with ESRD actually living good, fruitful lives with general good quality and increased longevity. Thank you very much, experts, for being here. Thank you, viewers. We'll be back again next week with more information about something else related to health.